Okay, hello everyone around the world. A very warm welcome to this webinar series where we're looking at the use of direct oral anticoagulants for the treatment of venous thromboembolism. You know, it's funny, I've said this multiple times and I'm a surgeon. I really ought to be able to pronounce venous thromboembolism that's associated with cancer. First off, this has been sponsored by an educational grant from Pfizer. I'm Dr. Jonathan Sackier, your moderator for today's discussion. I'm joined today by Dr. Mark Carrier from Canada. Good morning to Canada. Please introduce yourself to the audience.
Good morning. I'm Mark Carrier. I'm one of the hematologists at the University of Ottawa in Ottawa, Canada. Nice to be with you.
And it's lovely having you here. And also joining us is Dr. Harry Gibbs from Australia. Good evening to Melbourne. Please introduce yourself to the audience.
Thanks, Jonathan. I'm Harry Gibbs. I'm a vascular and internal medicine physician working at the Alfred Hospital and Monash University in Melbourne, Australia,
which I've had the great pleasure to visit. So today we've got two presentations, and firstly from Dr. Carrier, followed by Dr. Gibbs. So please use the chat box function. I think you'll see that there's a question mark, and I believe it's at the bottom of your screen. So you can ask questions, and we'll do our very best to answer them at the end of the presentation. So first of all, Dr. Carrier, off you go.
Hello, I'm Harry Gibbs. I'm a cardiologist and vascular physician in Melbourne, Australia, and it's my pleasure today to be able to discuss the important topic of the use of direct oral anticoagulants in cancer-associated venous thromboembolism. The association of cancer with venous thrombosis was made in the mid-1800s by a French physician, Armand Trousseau, and he's famously known for commenting, "Je suis perdu," when he discovered that he had an episode of venous thrombosis. And he realized the importance of this and went on, in fact, to die some months later from a cancer of the stomach. It became apparent that cancer and venous thromboembolism have a strong association. And in fact, about 20% of all episodes of incident venous thromboembolism occur in patients with active cancer. If you take the population of patients who have cancer, then about 10% of these will develop symptomatic venous thromboembolism during the course of their illness. And the outcomes, both for venous thromboembolism and for the cancer, are worse in patients who have venous thromboembolism in association with cancer. The modern approach to the management of acute venous thromboembolism was established by the landmark trial of Barrett and Jordan, published in The Lancet in 1960, showing that heparin followed by a vitamin K antagonist had a dramatic reduction in subsequent venous thromboembolism recurrence. It became apparent, however, that the outcomes of this standard approach with low molecular weight heparin followed by a vitamin K antagonist was less effective in patients with cancer-associated thrombosis, with both a significant increase in the risk of recurrence, which occurred about 3 times more frequently in those with cancer, but also in the important major complication of anticoagulant therapy, bleeding, which occurred at about twice the rate in those with cancer as those without. It was also noted that much of these recurrences and bleeds occurred during the phase when patients were being treated with vitamin K antagonists, and this led to the approach of studying monotherapy with low molecular weight heparin. Probably the best known of these studies is the CLOT study, which looked at monotherapy with the low molecular weight heparin dalteparin versus conventional therapy with dalteparin followed by a vitamin K antagonist. And in this study, the use of dalteparin had a dramatically lower risk of recurrent venous thromboembolism, but without an increase in the risk of bleeding. There were a number of other studies that have looked at monotherapy with low molecular weight heparin, and these have been systematically reviewed in this publication in the Cochrane Library. And these studies have confirmed that the use of low molecular weight heparin is associated with a significant reduction of recurrent venous thromboembolism without an increase in bleeding and with no change in mortality. That then brings us to the use of DOACs. DOACs had become established in patients without cancer as the standard of care. The pivotal trials looking at DOACs in acute venous thromboembolism had relatively few patients, however, with acute cancer. We now have 4 major trials that specifically have addressed the issue of the efficacy and safety of DOACs in patients with venous thromboembolism and active cancer. So the first of these trials was a Hoxi VTE cancer, a large study where patients received dolteparin for 7 days, followed by edoxaban. The SELECT-D trial was a smaller trial looking at the monotherapy with rivaroxaban. And Caravaggio and ADAM VTE both studied apixaban, and in each of these trials, the comparator was dolteparin. If we start with the Hoxi VTE cancer, in over 1,000 patients, the use of edoxaban was associated with a lower risk of recurrent venous thromboembolism. However, this came at the expense of more bleeding. The SELECT-D trial, which was a relatively small trial of patients receiving rivaroxaban, also showed that the investigational agent, rivaroxaban, was associated with a lower risk of venous thromboembolism recurrence than dolteparin. But again, this occurred with an increase in bleeding. The ADAM trial was a very small trial of apixaban, and again, there was a lower risk of recurrence with the use of apixaban compared to dolteparin. But in this trial, bleeding was relatively uncommon, and in fact, there was no bleeding in the apixaban arm. The second apixaban trial, Caravaggio, is the largest of the trials studying the use of DOACs in patients with active cancer and acute venous thromboembolism. And it also found a lower risk of recurrent venous thromboembolism with the active therapy of apixaban compared to dolteparin. But in this trial, there was no increase in bleeding. So the use of apixaban 5 milligrams twice daily seems to have a very good balance of safety and efficacy in this patient group. Not long after the publication of these papers, there have been, in fact, quite a number of meta-analyses that have been subsequently published, and this is one of those. They found that when meta-analysing the 4 trials that I've just discussed, it confirmed that there was a significant reduction in the risk of recurrent venous thromboembolism, which was reduced by about 40% with the use of a DOAC compared to conventional therapy with dolteparin. And this occurred with no increase in major bleeding, although you can see that there is some heterogeneity there with 2 of the trials, as I've mentioned, the trial using edoxaban and the trial using rivaroxaban, having a trend towards more bleeding. So what happens in the real world? The Garfield VTE registry was a large global initiative looking at patients with incident venous thromboembolism. And there were 10,000 patients enrolled, and treatment practices were recorded. The Garfield VTE registry was conducted prior to the publication of the studies specifically looking at DOACs in active cancer. But you can see from this slide that in spite of that, there were a number of clinicians around the world who still favoured the use of DOACs in cancer-associated thrombosis, and about 15% of patients were being treated. So it does appear that prior to the evidence being established in terms of the efficacy and safety, clinicians felt confident the DOACs were likely to be a worthwhile option in this situation. So what about guidelines? The American Society of Hematology have recently published guidelines for the management of cancer-associated venous thromboembolism, and they recommend that a DOAC, either apixaban or rivaroxaban, or low molecular weight heparin, may be used for initial treatment. However, it has been noted that patients, in particular with gastrointestinal cancers, may have more bleeding with DOACs, and so these agents should be used carefully in that subgroup of cancer patients. So where does that leave us now? I personally would recommend the use of a DOAC in cancer-associated venous thromboembolism with the following caveats. Firstly, patients with epithelial cancers such as gastrointestinal or urogenital cancers, where those cancers have not been resected, do have an increased risk of bleeding. And I think these drugs should be used with caution in those situations. It's uncertain what to do with patients who have extremes of body weight, and in particular, patients who weigh less than 50 kilograms or more than 140 kilograms. There is some uncertainty about dosing of DOACs, and in those situations, it's probably better to stick with the more conventional therapy of low molecular weight heparin. These agents are renally excreted predominantly, and so patients with severe chronic kidney disease with an eGFR of less than 25 probably should not receive DOACs, as it's uncertain as to whether dose reduction may be effective in patients with acute thrombosis. The use of low molecular weight heparin has been well established in this situation. And finally, patients with thrombocytopenia who have a greater risk of bleeding probably should not receive a DOAC, as it's uncertain as to what dose should be used. And in this situation, again, we have established approaches to the management using lower doses of low molecular weight heparin, although these are not necessarily backed by randomized controlled trials, but they certainly have been established through a clinical practice over many years. And most clinicians will be comfortable with using lower doses of low molecular weight heparin, and we just don't have the same experience with DOACs. But other than these particular groups, I would favour the use of DOACs in cancer-associated thrombosis. There's much greater patient acceptance, as the use of a tablet is much better tolerated than once or twice daily injections. And this has really been a major advance in this field. Thank you.
Okay, thank you very much for that. And let's see if we can get the next presentation up.
My name is Mark Carrier, and I'm a hematologist and professor of medicine at the University of Ottawa in Ottawa, Canada. It's a great pleasure to be with you today to have a discussion on direct oral anticoagulants for the management and treatment of venous thromboembolism in the setting of cancer. Before starting, it's always important to have a look at potential conflicts of interest of the speakers. My honorarium are given to the Ottawa Hospital Research Institute and used for residents and learners research and education, but they remain potentially important conflicts that you should be aware of. So over the next 45 minutes or so, I'd like to do three things. The first thing is I would like us to review the epidemiology and the clinical relevance of venous thromboembolic disease among cancer patients, just to see where we're at. Is it associated with morbidity, mortality? Then we'll summarize the evidence on the efficacy and safety of the different anticoagulant regimen. We'll talk about low molecular weight heparin, of course, vitamin K antagonists, but we'll focus on the direct oral anticoagulants. And then we'll discuss how clinicians like you and I need to tailor anticoagulation based on specific patient characteristics in order to make the right decision for our patients. So let's start with a case. This is Mr. MT. He's a 77-year-old gentleman with hormone-naive metastatic prostate cancer. He has metastatic disease to the bone and brain. He was recently started on deprivation therapy and docetaxel. He presents to the emergency room with progressive shortness of breath, pleuritic chest pain. His vitals are slightly abnormal and starting to raise some concern. So he's tachycardic. His blood pressure is reasonable, but he's requiring oxygen and needs 3 liters per nasal cannula to maintain good saturation. His basic blood work is within normal limit, with normal hemoglobin, platelet count, and a renal function that is within normal limit as well. Obviously, the emergency room docs are thinking that this could be related to pulmonary embolism. Send him to the CAT scan, and he's diagnosed with a saddle or a large pulmonary embolism. He's started on parenteral anticoagulation, IV heparin or low molecular weight heparin, because we're not too sure which direction he will take. Will he stabilize, or will we have to escalate the care? And therefore, there's a decision to keep him in hospital, start him on parenteral anticoagulation therapy. Now, as you're probably aware, venous thrombosis is not very common in general population. We're talking about 1 or 2 per thousand folks. But as soon as you have a cancer diagnosis, you're increasing the odds by fourfold. And if you're a cancer patient starting chemotherapy, you're increasing this odds ratio by 6.5-fold. So just putting these two numbers together, we're no longer talking about 1 in 1,000, but we're really talking about 1 in 200. But the cancer journey is complex, right? It's not only about having a diagnosis, initiating anti-cancer treatment. These folks are often in hospital for complication of the chemotherapy or anti-cancer treatment. They need to have central venous catheter being inserted because of chemotherapy deliverance or blood products. They need biopsies, surgeries. All of these things are small risk factors that will make them go through the threshold of having a symptomatic event. So actually, if you follow patients from the time of diagnosis until the end of life, the incidence of the disease is much more common. And Andrew Cohen and colleagues from the United Kingdom has estimated that it's 6 per 100 patient years. And therefore, about 1 in 20 folks with cancer will have some form of blood clotting complication throughout the cancer journey. Now, not all cancers are the same, right? Some cancers that we think about are really associated with a high risk of having blood clotting complication. You're probably thinking, well, gliomas, stomach cancer, G junction, pancreatic cancer, all of these types of diseases or cancer are really prothrombogenic and likely to cause thrombotic complication. I've highlighted on this slide pancreatic cancers because the incidence is 15 per 100 person years. So very common, almost 1 in 5 folks with pancreatic cancer will have some form of blood clotting complications. But when you and I reflect on who we actually see in clinic, sure, we see pancreatic cancer patients and these types of tumors that are really prothrombogenic. But when we look at the burden of VTE, who's actually showing up, it's not the pancreatic and the stomach cancers of this world. It's really prostate cancer in males and breast cancer in women, simply because these types of cancers are so common in general population that although the underlying risk of VTE is lower, at the end of the day, we see more clots in these patients. And the reason why I'm saying this is we need to create awareness to make sure that we think about blood clots when folks are presenting with signs, symptoms, and me included. Often we don't think of it as being an important cause of symptoms, and that leads to increased morbidity and mortality for these patients. So although Mr. MT has prostate cancer, it's not a prothrombogenic type of cancer per se, because prostate cancer is so common in general population. It's not unusual to see deep vein thrombosis and pulmonary embolism in these patients. And as I mentioned, venous thrombosis is not only common in cancer patients, it's also associated with significant morbidity and mortality. Thromboembolism, so arterial and venous clots, are the second leading cause of death in cancer patient, equal with infection following cancer progression per se. And the reason why I'm saying this is clinicians and healthcare providers and patients are well aware of the potential consequences of infection in the setting of cancer, right? They know that if they feel unwell, they need to take their temperature. If it's high, they need to seek medical attention because they may have febrile neutropenia. But ask any of these patients if they know what signs symptoms of PEs are. Most of them don't know. And the reason for that is lack of awareness, and that leads to morbidity and mortality. If you have a reflection of your practice this week or last week, you probably got a call from a radiologist with incidental PE. When you talk to the patient, most of these patients actually have symptoms, but they didn't know it could be related to a clot. They thought it was the underlying disease or the ongoing treatment. So creating awareness about these signs, symptoms be, can lead to decreased morbidity and mortality because we have very effective medication, very effective anticoagulants that can stabilize the clot, make sure there's no recurrence or worse morbidity or mortality. So Mr. MT, he's admitted to hospital. His conditions improve with parenteral anticoagulation during his hospitalization. On post-admission day 3, he's back on room air. His vitals are normal. He's ready for discharge. the question to you is, well, on which anticoagulant, the type and dose, will Mr. MT be discharged on? Will you continue a parenteral type of blood thinner? Will you go for an oral type of blood thinners? We'll try to have a discussion today about the different options and how to tailor anticoagulation in that setting. You're probably wondering, well, what are the factors that I need to think about when I make a decision about proper anticoagulation for cancer-associated thrombosis? Well, clearly the first thing to think about is efficacy and safety. And there's a number of additional factors that we'll go through over time. Okay, so when we talk about efficacy and safety, we have to have a reflection about all the different options. And that has evolved dramatically over time. If we go into the early 1900s with unfractionated heparin, then vitamin K antagonist, then the low microweight heparins that could be given subcutaneously, when you have a reflection about the CLOT trial, this is the landmark trial that has compared parenteral anticoagulation with low microweight heparin to vitamin K antagonists and followed patients over time, showed more efficacy and similar safety. This in the early 2000s has changed completely how we manage cancer-associated thrombosis. And for the past almost 2 decades, we've been using low microweight heparin as the standard of care for management of cancer-associated thrombosis. But in the past 2 years, a number of studies have looked into the directal anticoagulants compared to low microweight heparin, and we'll have a look together to see how this has changed practice. Remember all the 6 randomized controlled trial comparing low microweight heparin to vitamin K antagonist that led to that change in clinical practice guidelines in the early 2000s? I've highlighted the CLOT trial because it's the landmark trial comparing nalteparin to vitamin K antagonist, but all the different low microweight heparins were compared. 6 randomized controlled trials were pooled. And if you look on your left side, when you look at efficacy, efficacy is always measured as the chance of having a second blood clot despite anticoagulation, what we call recurrent VTE. If you look at efficacy, low microweight heparin decreased the risk of recurrent VTE by about 50%. If you look on your right-hand side for major bleeding, you can see that the same studies comparing low microweight heparin to vitamin K antagonists did not show any difference in major bleeding troubles. And that's why it led to a change in clinical practice. Now, you may be wondering, what is the definition of major bleeding, Mark? Well, major bleeding definition is from the International Society of Thrombosis and Hemostasis, the ISTH definition. And that means that the patient needs to be bleeding, of course. They need to have a drop in their hemoglobin by 2 grams or 2 units of packed red blood cell transfusion, or a bleeding in a critical site like brain or joint or retroperitoneal, or they need to have a fatal bleeding event, and that would be captured within major bleeding. Now, I mentioned that since then, a number of trials have compared the different direct anticoagulant to low microweight heparin, which is the standard of care for cancer-associated thrombosis. And the most recent one was recently published, Caravaggio. And we will go through 3 large randomized controlled trials together and see if we can incorporate that into clinical practice and use them in patients with cancer-associated thrombosis. Now, a number of clinical practice guidelines have met and looked at the data, and one of the most recent one is the NCCN guidelines from the United States. And based on the data that we'll look at, they are saying that maybe DOACs should be the preferred option for patients with cancer-associated thrombosis, except those that have gastric and G junction lesions. We'll go through the data and see why that is. And they provide different options with different categories. So they would say apixaban and edoxaban would be category 1, rivaroxaban would be category 2A, and the last direct anticoagulant, the bigatran, should not be used because of the lack of data. So my job over the next few minutes is to go through the data and see at the end if we agree with the NCCN recommendation on the management of cancer-associated thrombosis, and can we incorporate that into our daily practice. Now, the first trial that was published in February 2018 was the Okusai VTE cancer trial. This is a large, open label, non-inferiority randomized controlled trial, including patients with cancer-associated thrombosis, and they were randomized to the comparator, that's dalteparin, low molecular weight heparin, at the clot doses, so that's 200 units per kilogram per day for the first month, then 150 international units per kilogram per day thereafter, or 5 days of low molecular weight heparin, then edoxaban. Edoxaban at a dose of 60 milligrams once a day, except if they had low weight, lower creatinine clearance, or drug-to-drug interaction, then a dose of 30 milligrams was used. Now, the Okusai VTE cancer trial followed patients for at least 6 months and up to 12 months. After the 6-month mark, it was up to the patient and the investigator to decide if they were going to continue the study product to have additional data for the second 6 months, right, for secondary prevention, long-term treatment. So that's the first difference. Usually when we talk or think about cancer-associated thrombosis trials, we think about a 6-month follow-up period. This is a little bit different, so 12 months. And the other difference is their primary outcome. The primary outcome was composite of both efficacy and safety, so recurrent VTE or major bleeding, regardless of duration of therapy over time. Now, the patient characteristics are what we would expect for or from the other cancer-associated thrombosis trial. I want to highlight 2 things here. The first one is the 4th row, where we look at symptomatic venous thromboembolic event. You can see that 2/3 of patients had symptoms, 1/3 of patients had incidental VTE, so incidental PE, and it's the first time that we're starting to randomize patients with incidental finding, because this is something we're seeing quite a bit. And remember, a lot of these patients will still have symptoms, but it's important to keep that in mind. And then the last line is treatment duration, because remember, this is an open design, non-inferiority randomized controlled trial. So patients, obviously, they know if they're self-injecting or taking a tablet. So you can see last line there, there's a difference of about 1 month between the intervention and the comparator. And that will be important for us to keep in mind when we have a look at the results. Now, I've put a slide here for a type of cancers, simply because I showed you that the NCCN is saying, well, be careful with DOACs in gastric and GE junction. So I thought it'd be important to highlight the percentage of patients with gastrointestinal type of tumors that were included in the Okusai VTE cancer trial. So about 15% for colorectal, 7 to 10% for pancreatic epitheliobiliary, and about 5% for upper gastrointestinal tract. Now, if you look at the primary outcome measure, remember this is a non-inferiority trial design, so this will be your first line. You can see that edoxaban is non-inferior to dalteparin for the primary outcome measure of recurrent VTE or major bleeding. But you and I are clinicians, and we want to see the component of the primary outcome. So is it more effective or more safe, right? So if you look at recurrent VTE, you can see that folks that received the direct anticoagulant, in this particular case, edoxaban, had a lower rate of recurrent VTE, the hazard ratio of 0.77. That was not statistically significant. But that came at a higher price of increased risk of major bleeding complication, as you can see, and that was an hazard ratio of 1.71, and that was statistically significant. It looks like most of the difference in the major bleeding difference between the 2 groups is coming from upper gastrointestinal tract type of bleeding. And I'll come back to the details later, because it'll be important for us to keep that in mind when we tailor anticoagulation. Now, the second trial is the SELECT-D trial, a more modest trial, a sample size of 406 patients. They included patients with cancer-associated thrombosis. The comparator is, again, dalteparin, same dose we talked about, or rivaroxaban, but at the DVT and PE dosing. So remember, this is 15 milligrams PO BID for 21 days, then 20 milligrams PO daily thereafter. Following patients up to 6 months, the primary outcome measure was efficacy with recurrent VTE. Now, this was a pilot study, so it isn't really designed to look at difference between the 2 arms, but we can still have a look at it. It is important that it was powered to detect a risk of recurrence in folks that receive rivaroxaban and to ensure that the upper bound of the 95% confidence interval for recurrent VTE was not over 8%. And during the trial conduct, they thought that they could increase that to 9%, and therefore the sample size was decreased from 530 to 406. They also initially planned a second randomization after 6 months because a big knowledge gap, as you know, is how long to treat these patients for secondary prevention. But it was hard to randomize folks, so this was deemed to be not feasible. But we have a look at 406 patients. And again, similar to what we saw for Okusai VTE cancer, when you look at folks that received a direct anticoagulant, in this particular case, rivaroxaban, it was associated with a lower rate of recurrent VTE, and that was statistically significant. It was associated, again, with a slightly increased risk of major bleeding. It wasn't statistically significant in that particular study, but it's important to know that the DSMB, the Data Monitoring and Safety Board for the study, asked the investigators to stop recruiting patients with gastric and GE junction during the trial conduct, probably because they saw a similar signal. So it led to a major bleeding difference that is not statistically significant, but might have been higher if not acted on. What's interesting with SELECT-D is the difference in clinically relevant non-major bleeding, and there's an increase of about 9% for folks that receive rivaroxaban. Now you're probably wondering, well, Mark, what is a clinically relevant non-major bleeding? So we talked about the definition of major bleeding, right? So if you think about a patient that's coming in with hematuria to your emergency room, requires cystoscopy, whole bladder irradiation, requires urology, goes to the OR, has a unit of packed red blood cell. I think you and I agree that this is not necessarily an insignificant bleeding. This is clinically important, but it doesn't meet the major bleeding definition. And therefore, these types of bleeding would be captured in clinically relevant non-major bleeding. And for SELECT-D, about 50% of folks that had clinically relevant non-major bleeding had hematuria. And that may be important for you and I to keep in mind when we make a treatment decision. Now, the last but not least Caravaggio trial is, again, a large phase 3 open label non-inferiority trial design, including patients with cancer-associated thrombosis, randomized to dalteparin, the same dose we talked about, or apixaban at the DVT and P dosing, and that's 10 milligrams PO/BID for 7 days, then 5 milligrams PO/BID thereafter, up to 6 months. Their primary outcome, recurrent VTE, so efficacy for non-inferiority, and secondary outcome measure, of course, includes major bleeding, the ISTH definition, but it also included bleeding that necessitated surgical intervention, so a little bit more broad, and also looking at clinically relevant non-major bleeding. Now, similar to Okusai VTE cancer, the patient characteristics are very, very similar. Again, if you looked at the fourth line, there's 20% of folks that were admitted or enrolled into the study with incidental PE. It was capped in Caravaggio to 20%, so that is important to keep in mind. And then when we look at the type of cancer, more specifically the gastrointestinal type of cancer, you can see that about 20% had colorectal, about 7 to 8% pancreatic or hepatobiliary, and again, 4 to 5%, similar to Okusai VTE cancer, had upper gastrointestinal tract type of bleeding. Now, if you look at the primary outcome of the study, remember non-inferiority trial design. If you're looking at folks that receive direct anticoagulant, apixaban for this particular trial, you can see that folks receiving apixaban had a lower rate of recurrent VTE, with a risk ratio of 0.63, so statistically significant for non-inferiority, but did not cross the boundary for superiority. And when you look at the component, it seems to be driven mostly by recurrent PE. And what's different with Caravaggio compared to SELECT-D and Okusai VTE cancer is the major bleeding difference between folks that receive direct anticoagulant or low molecular weight heparin. And you can see that there are no difference between major bleeding. Now, Caravaggio was just recently published, right? And they had heard about the gastrointestinal type of bleeding from Okusai VTE cancer and maybe SELECT-D. So the investigators pre-planned an analysis of gastrointestinal major bleeding. Now, this was not defined before starting the study conduct, but it was defined before doing the analysis. And you can see here when you look at the component of major bleeding, when you look at gastrointestinal major bleeding, there are no difference between apixaban and dalteparin. If you look at clinically relevant non-major bleeding, there's a slight increase for apixaban, for folks receiving apixaban, a difference of only 3% that was not statistically significant. Most of the clinically relevant non-major bleeding, folks had hematuria and upper airway type of bleeding. Again, important for us clinicians to keep in mind when we tailor anticoagulation. Now, what if we put all these three trials together? Well, there are numbers of systematic review and meta-analyses that have done that. And you can look on the top, recurrent VTE at 6 months, combining Okusai VTE cancer, SELECT-D, and Caravaggio. You can see that folks receiving the direct oral anticoagulant had a lower rate of recurrent VTE with a risk ratio of 0.68 that was not statistically significant, but very close. And that seemed to come at an increased risk of major bleeding. When you pull the three trials together, you can see that SELECT-D and Okusai VTE cancer associated with slightly increased risk of major bleeding, not so much for Caravaggio with apixaban, but when you put them together, there's still an increase of about 36% that was not statistically significant. So we talked about efficacy and safety. Then the next question is, well, Mark, how do I decide? In the early 2000s, we stopped using vitamin K antagonists. Everybody's on low molecular weight heparin. Now there's sure the DOAC are associated with more efficacy, but there's a safety signal, at least for some of them. How do we decide who's starting on what? And I think these are the additional risk factors that are important to consider to make a treatment decision. I think the first one is tumor type. You've heard this already. But when we looked at Okusai VTE cancer and we looked at major bleeding, the bulk of the difference in major bleeding was really related to a difference in upper gastrointestinal type of bleeding in folks that received edoxaban. And if you want to look at it a bit more granularly, a post-hoc analysis of the bleeding event of Okusai VTE cancer, stratifying patients according to their cancer type, non-GI cancer on your right-hand side and GI cancer on the left-hand side, you can see that folks with GI cancer had a higher risk of major bleeding complication if they received edoxaban. The hazard ratio was around 4. And therefore for therefore for Okusai VTE cancer, it looks like the increased risk of major bleeding complication was in folks that had gastrointestinal type of cancer that had upper gastrointestinal type of bleeding. And therefore we'll need to keep that in the back of our mind, because if we have a patient with GI tumor, maybe we'll need to look very specifically at these patients to decide if they should receive a direct anticoagulant or edoxaban specifically. It's the same story for SELECT-D. Remember, more modest sample size, so event rates of major bleeding that are more modest as well. When you look at the differences between folks that had major bleeding complication with rivaroxaban dalteparin, the excess major bleeding with rivaroxaban was mainly due to gastrointestinal bleeds, mostly GE or gastric type of tumors. And as I mentioned, this is not the case for Caravaggio. No difference in gastrointestinal type of tumors, maybe a slight increase in folks that had genitourinary type of tumors, similar to what we discussed for SELECT-D, but also seen in Okusai VTE cancer when you look at major bleeding event, but very small, as you can see, 4-to-1. So a little bit unclear, but maybe hypothesis generating, at least making sure that we're mindful of it. Now, as clinicians, you and I often want to know what the clinical course of these major bleedings, and do they lead to really bad prognosis for our patients? And on this particular slide, we're looking at Okusai VTE cancer and Caravaggio, the two post-hoc analyses of bleeding, and then looking at clinical course depending on severe categories. And obviously, the more severe, the worse outcomes, and that's worrying us as clinicians. And you can see for category 3 and 4, it's very rare, independent on the type of blood thinners, and really no difference between a direct oral anticoagulant and dalteparin. And similarly, hospitalization or fatal bleedings are also relatively rare, and no big difference between a direct oral anticoagulant or a low microwave heparin. Again, reassuring that although these major bleedings occur, when you have a stratification of these major bleeding, most of them will not lead to emergent type of procedures or being fatal in nature. The other thing that we often think about as clinicians is the presence of CNS Mets or primary brain tumors, for example, and that's important to keep in mind. And the reason for that is because they were not included in Caravaggio. Patients with primary brain tumors or known metastatic disease in the brain were excluded. They were included in Select D and Okusai VTE cancer, but very, very few patients were included. We're talking about 1 or 2%. So we don't have a whole lot of data on it. And you're probably well aware that if you look at the American Society of Clinical Oncology or any clinical practice guidelines, they would recommend that if your patients with brain mets or primary brain tumors has a new indication for anticoagulation, that you start anticoagulation. And this is based on the systematic review from Jeff Zwicker and colleagues that was published in JTH in 2016, looking at all the studies that included patients with primary brain tumors or intracranial disease with metastatic disease and comparing the risk of intracranial hemorrhage in those that receive anticoagulation or not. Now, these are small numbers and it's a mixed bag of indication, mixed bag of low microwave heparin and vitamin K antagonists. But you can see that when you do the pooled rates, the odds ratio is right at 1. So no increased risk of having intracranial hemorrhage complication if you have brain mets. It's a little bit different if you have primary brain tumors. The odds ratio is increased, but then again, these patients are really high risk of having recurrence. So this is a little bit of a different battle for clinicians to do the risk and benefit ratio. Now, what about is data for patients with intracranial brain mets or primary brain tumors on the direct anticoagulants? Again, very, very few data. The same group actually published a retrospective observational study, including 67 patients with primary brain tumors and 105 patients with intracranial metastatic disease. Some of them on low microwave heparin, mostly enoxaparin because it was based in the US. Some of them on DOAC, most of them on rivaroxaban. You can see for patients with primary brain tumors that no patients with brain tumors receiving a DOAC had an intracranial hemorrhage. And again, there is no difference in the risk of intracranial hemorrhage for patients with brain mets if they receive the DOAC or low microwave heparin. So a little bit of reassuring data, hypothesis generating, but reassuring data that maybe the presence of intracranial disease is not an important factor to consider. You need, as a clinician, to use whatever you feel comfortable about. It may be parenteral low microwave heparin because it's slightly shorter half-life, and you want to challenge patients to that before initiating a drug, and that would be completely fine. But you can also, if it's a non-complicated patient with, for example, Mr. MT with brain mets, maybe that's something that you want to consider as a direct anticoagulant without too much concern. The other factor to consider is drug-to-drug interaction. And there's no doubt that the direct anticoagulants have less drug-to-drug interaction compared to vitamin K antagonists, but they have more than low microwave heparin. They're metabolized through the CYP3A4 in the liver and absorbed through the glycoprotein P transport pathway. And therefore, if you have other medication that are strong inhibitors of the CYP3A4 and glycoprotein P, that may increase the plasma concentration of the DOACs and lead to bleeding complication. And if you have inducers of both pathways, that may decrease the levels, and maybe your patient would be at a high risk of having a recurrent event. Now, these are theoretical in nature. Are they associated with clinical findings is still unknown. There's really little data to guide clinicians on this. There's certainly no data for cancer-associated thrombosis, but there's a little bit of data outside of that. So this is a large observational cohort study assessing the risk of hospitalization for hemorrhage in patients on a DOAC that received clarithromycin, for which there's a well-known documented drug-to-drug interaction, versus azithromycin, for which there are not. And you can see that here on table 2, that patients that had the drug-to-drug interaction had a small but statistically significant increased risk of 30-day visit to the emergency room with major hemorrhage. And therefore, while we're waiting more data to see if drug-to-drug interactions are important, it may just be clinicians just need to be mindful that if there are a potential interaction, try to find an agent that has no interaction, discuss with your pharmacist, different drug interaction from one DOAC to the other, different interactions between low molecular weight heparin and DOACs, and patients may go from parenteral to oral and vice versa based on that. Last but not least, the most important factor to consider is patient's perspective, because when patients are seeing me in clinic with their blood clot, they don't see themselves as a blood clot patient. They see themselves as a cancer patient first, right? That's the most important thing on their mind. And what they're saying and thinking is, Mark, do whatever with your anticoagulants, but do not interfere with my cancer treatment. Don't delay my surgery. Don't change my chemotherapy regimen. That's the first thing on their mind because they really want to get to the end of the cancer treatment. Obviously, the second thing is efficacy and safety of the different anticoagulant. We just had a long discussion about that. And lastly is the route of administration. And therefore, patients will understand if they have to go from parenteral or oral back to parenteral, depending on what's going on in the cancer journey. If they have surgery, they have important drug-to-drug interaction, or if they have any significant nausea and vomiting for a short period of time. It's just a matter of sitting down with them and discussing why you make a treatment decision using one agent over the other. Now, these results, these quantitative studies were done at the time where low molecular weight heparin was the standard of care. And the same group, Simon Noble and colleagues from the United Kingdom, repeated qualitative interviews of patients alongside the SELECT-D study, remember, that compared rivaroxaban to the low molecular weight heparin, and more or less found the exact same attributes. And therefore, it doesn't matter if low molecular weight heparin was the standard of care. Now we have DOACs. Patients still think in a very similar way. First, do not interfere with my cancer treatment. Give me something that is effective and safe. And then we'll talk about route of administration afterwards. So after reviewing all the data, looking at different factors, how are clinicians incorporating these new data into clinical practice? Well, I think I agree with the NCCN that DOACs are preferred over low molecular weight heparin for most patients with cancer-associated thrombosis. Clearly, as we saw, the evidence is strongest for apixaban and edoxaban because they have the phase 3 open label non-inferiority randomized control trial. There's still some data with rivaroxaban because there's a randomized trial. More data is coming in the near future, so we'll be able to add more data and maybe stratify patients further. And I agree with them that certain tumor type, especially gastrointestinal type of tumors, especially if it's non-resected, we need to be very mindful about that. I think if you have known GI toxicity or absorption concerns like gastric resection, for example, or Roux-en-Y, you need to be mindful of that and pick your anticoagulant accordingly. I think it's important to think about DDI because now we have more options in our toolbox of anticoagulants, and therefore you probably should pick an agent for which there are no important drug-to-drug interaction. And then having said that, including the patient's preference, because when you talk about efficacy and safety, the absolute difference in benefit and arms between different agents are relatively small, and putting that into perspective with patients will be very, very important. So for Mr. MT, he was doing better post-op day 3. He was discharged on a DOAC. And because he only had 3 days, that could be rivaroxaban or apixaban. Because remember, if you want to use edoxaban, you need to use 5 days of low molecular weight heparin before using edoxaban. And over time, you see him in follow-up. Symptoms have completely resolved. He's doing well without any signs, symptoms of recurrent VTE or bleeding. And you continue long-term follow-up for him. So what I wanted to do was to remind you that venous thromboembolic complications are common in patients with cancer. They're associated with morbidity and mortality. We should initiate anticoagulation as soon as there's a suspicion because we have great drugs now, parenteral and oral, that can provide therapeutic dose of anticoagulation right away. In order to make a decision on how to tailor anticoagulation, I think we need to think about tumor type, bleeding risk, drug-to-drug interaction, and incorporate patient's preference. Thank you very much for your time.
Okay, thank you very much, Mark, for that very thorough and fascinating presentation. There's a number of questions. I'm going to take my prerogative and ask mine first. You mentioned, I think, Harry, that at the beginning that 20% of all venous thromboembolism was due to cancer, if I got that correct. Does that mean that if someone presents with a venous thromboembolism that they merit a full workup to exclude an obscure cancer that's otherwise not presented?
Yeah. So coming back to those data, about if we take all new cases of venous thromboembolism, about 20% occur in the setting of active cancer. About another 40% occur with some provoking factor such as surgery, trauma, and so on, hospitalization. And the remaining 40% are otherwise unexplained or unprovoked. And it does always raise the question as to whether someone presenting with unprovoked venous thromboembolism may have an underlying cancer. But there have been 2 randomized controlled trials that have looked at the question of whether a very extensive investigation should be undertaken. And there was no improvement in outcome with an aggressive investigational approach in that situation. So the answer is no. However, of course, you should perform physical examination and take a history and see if there are any concerning symptoms or any physical signs on examination. And it is appropriate for patients to have their age-appropriate screening, so mammography for women and so on. But it's not an event that requires a specific aggressive look for cancer.
Yes, I would just hark back to my training in Liverpool, and where we were told that, how shall I put this discreetly, if you didn't put your finger in it, you're going to put your foot in it, and that a full, proper medical history and physical examination was necessary, and that included a rectal exam. Let's see, a question coming here. What about drug-drug interactions of direct oral anticoagulation therapy and cancer therapy? Mark, you mentioned patients obviously wanting their cancer taken care of first of all. But would you like to address that first?
Of course. As mentioned, DOACs have less drug-to-drug interaction than warfarin or vitamin K antagonists, but they are metabolized through the liver, through the CYP3A4, and absorbed through the glycoprotein P. And if you do have strong inducers or inhibitors of these pathways, then you can increase or lower the level of the DOAC. So you need to be mindful of that. There are a number of tools available, Lexicom, for example, that can help clinicians to see if there's an important drug-to-drug interactions to consider. And also having a good discussion with your pharmacist is desirable. It's important to keep in mind that these drug-to-drug interactions are theoretical in nature, and there's not a lot of clinical data to support it. I've mentioned a little bit of the data in the presentation. There's more data that will be presented at the ISTH meeting through the SSC and cancer and hemostasis. And there's a number of observational cohort studies now trying to look specifically for data in patients with cancer receiving DOACs and chemotherapy, especially immunotherapy, targeted therapy. All of these things are important to keep in mind because they were underrepresented in the randomized trials. So these drug-to-drug interactions are theoretical in nature. If you do know one, then you can use an alternative. The different DOACs have different profiles for their interactions, or to use a parenteral agent while the patient is on that specific treatment regimen. Until we have more data, of course.
Yes, that's always a good answer when we have more data. And then, of course, we'll have to do another webinar to discuss it. Harry, let's start with you, but I'd like you to both weigh in. What about the role of patient education in the prevention of cancer-related venous thromboembolism? You go first.
Yeah. Well, of course, the reason that patients get venous thromboembolism in cancer are multiple. Some would be related to the biology of the cancer. Sometimes it's related to procedures that patients undergo. It may be related to dehydration because of vomiting and anorexia and so on. So there are a number of ways of trying to reduce the development of venous thromboembolism. Most of those ways really have revolved around pharmacological measures, but I think that it is important that patients be advised to do simple things such as maintain mobility, maintain adequate hydration, and so on. But Mark also touched on the very important point that patients are often unaware of the symptoms of venous thromboembolism. And I think it is important that they be educated along those lines so that they can present early if they develop those symptoms, rather than potentially presenting with sudden death, which certainly occurs. And so, I think that's something that is extremely important.
Want to jump in, Mark? Do you have any additional comments?
Well, I completely agree with Harry, and there's part of the issue is implementation of VTE education and discussion sometimes about pharmacological trauma prophylaxis, and clinicians and medical oncologists, hematologists are busy and it's hard to do so. But there's a nice recent article looking at an implementation of VTE education and discussion about primary prevention that was done in the United States in the state of Vermont. And through electronic medical records, they're able now to identify patients that might be at high risk of VTE, but also high risk of bleeding. And for these patients, using a multidisciplinary approach, including nurses and physician extenders and other people, to try to provide them with some education so that they can be aware of the signs, symptoms, and in the case where the risk-benefit ratio is favorable, then to have a discussion about pharmacological trauma prophylaxis in high-risk patients. And when they, in that particular study, about 25% of folks receiving chemotherapy were deemed to be at high risk. So about 1 in 4 patients should have that discussion.
Well, I'd thank you for that. I'd like to stay with you and then ask Harry if he would like to add any further commentary. How long do you anticoagulate cancer patients for, and do you differentiate between so-called active and inactive or chronic cancer?
So patients with cancer-associated thrombosis are typically treated for 6 months of anticoagulation, at which point in time the clinician makes a decision about risk-benefit ratio. After 6 months, the initial clot is cured. The rationale to continue anticoagulation is for what we call secondary prevention, or preventing another blood clot from happening. Usually, if the patient still has underlying cancer ongoing treatment, these risk factors are the reason why the patient had the initial clot to begin with. So usually we tend to continue anticoagulation when the patient has active cancer or ongoing treatment. And if they become cancer-free, then we usually stop or feel more comfortable stopping anticoagulation at that time. So if you look at clinical practice guidelines, it's an indefinite duration of anticoagulation based on risk-benefit ratio and risk factors. There's still a little bit of knowledge gap about dosing. And then there's ongoing trials looking at dosing for secondary prevention in that patient population. So hopefully soon we'll have a bit more data to guide clinicians.
Harry, do you want to add anything?
I guess might note that in the non-cancer group, we have very good data now showing that secondary prevention with low intensity long-term anticoagulation, so that's a half a dose of apixaban or a half a dose of rivaroxaban, is extremely safe and extremely efficacious. So, in terms of safety, the major bleeding rate in that group of patients, so this is a group of patients who've had an initial course of 6 months of full therapeutic anticoagulation, who then go on to low intensity anticoagulation. In that group of patients, major bleeding comes in at at a 0.5% or less per annum. So it's an extremely safe therapy. And that's really changed our approach to this, in that many patients will go on to have a low-intensity anticoagulant therapy. We don't have the same information about the cancer-associated group, but as Mark's suggested, those trials are ongoing and we should have information about that. But I think, the important point here is that once patients are through the first few months of anticoagulation with a DOAC, if they haven't bled, the risk of bleeding is really pretty low. So that I would tend to favour ongoing therapy while there's any, ongoing risk factor, such as the presence of a cancer, for a long term.
Yeah, so what's the trend in cancer-related venous thromboembolism and treatment with DOACs as opposed to conventional treatment? And how has that changed over the past 5 years? Neither of you. One of you. Harry, you go first.
Yeah. So I'll go first. So, so I think that the trend is one of a pretty rapid uptake of the use of DOACs in cancer-associated thrombosis, which really has occurred over the last couple of years. Prior to that, there was uncertainty, and low molecular weight heparin, I think, remained the standard of care. But with the publication of the trials that Mark and I have both presented, it's really changed. And there's certainly in Australia anyway, a pretty strong uptake of DOACs for this indication.
I completely agree with Harry. And as we discussed, the clinical practice guidelines are now suggesting DOACs as first line. The American Society of Hematology in 2021 suggest DOACs over low molecular weight heparin for short-term treatment, so the initial 3 to 6 months. The NCCN mentioned that DOACs is the preferable option for a majority of patients. And then when you ask patients, the Simon Noble and colleague from the United Kingdom, when they ask patients about their preference, obviously a tablet is better than a needle in most cases, but in the context of cancer, throughout the cancer journey, a needle is acceptable too, but you have to fulfill these other things. So if you have efficacy, safety, and no interaction with the anti-cancer treatment, then obviously tablets is the way to go. And that's part of the reason why we're seeing as mentioned, quite an uptake in clinical practice.
I'm going to come back to you both in a second and ask you to make a closing statement, like, one key takeaway, if you will, for the audience. But whilst you're getting your thoughts in order, I really want to thank the audience for taking the time out of their busy days to listen to these gentlemen who've taken time out of their busy days from around the world, and we've truly got the United States, Canada, and Australia covered. And thank you for the wonderful presentations. We're thrilled to have had you on, to have your expertise, and obviously everything you've done for science and everything you've done for the patients. I'd like to thank EMG for hosting this, and again for the kind sponsorship from Pfizer. So I hope that's given you sufficient time to come up with something pithy and meaningful as a takeaway. Harry, would you like to go first?
Sure. Well, I guess my takeaway is that it is now well established that DOACs are a very reasonable option for treatment in patients with cancer-associated thrombosis.
And my takeaway is in a similar way. We now have many options to manage cancer-associated thrombosis, so we can tailor anticoagulation based on patient characteristics and patient's preference. And therefore, this is just good for everybody, patients, clinicians, and everybody in the healthcare system.
In Hollywood, this would be considered, what I'm about to do would be considered, a really critical spin at the end, because we've said our farewells. I've asked you for a closing statement, and a question has popped up that I just cannot ignore. It's a pithy one. What about the exclusion criteria of the DOAC studies? Is it right that there were more than 30 exclusion criteria in the Caravaggio study? So the patients were a very targeted selection. And if so, how representative of those studies? So I think a brief answer would be great. Who would like to take that on?
The point is well taken that all randomized controlled trials, including those that have compared low molecular heparin to vitamin K antagonists, have a lot of exclusion criteria trying to make sure that the patient included have high risk of recurrence but low risk of bleeding. So clinicians need to be mindful of that, no doubt. We've tried to highlight during the presentation, the example was Caravaggio, that, for example, patients with brain and metastatic brain disease were not included, and thrombocytopenia was not included. These are challenges for which there's still knowledge gap, and that you need to be mindful of when you're taking care of patients.
Anything to add to that, Harry?
I guess, well, I'd agree completely with what Mark said, but it's always a situation with randomized controlled trials that there need to be strict inclusion and exclusion criteria. What then happens is if the investigational agent, which in this case are DOACs, do seem to have benefit, then observational studies, which are either planned or pre-planned or retrospective, or in these days often by using database analyses, give us some confirmation that the finding of the randomized controlled trial is actually relevant in common day-to-day clinical practice. And we will get those confirmatory real-world evidence trials. And I guess as clinicians, some people are very early adopters of new therapies, and I have been personally, but others are more skeptical and like to wait until the real-world evidence is out. And I think that's up to your own personal philosophy. It's neither right nor wrong. But I think that we certainly have, a really strong basis now to believe that these drugs are likely to be effective in a broad range of patients with cancer. And we'll find out as time goes on exactly how this pans out in sort of more general clinical practice.
Yeah, that was why I really wanted to see that one answered, because of course it is a pivotal issue. If everyone were to be tentative, we would never get anywhere, and we would never discover what actually does and does not work in the real world. And when you've got a patient in front of you who's got a pressing issue, you use the best available evidence at that given time for that given patient. So again, gentlemen, thank you so much for your time, for your expertise, and for your kindness. So again, thank you to our audience. We hope that you found it as useful and as educational as I did. And for everyone out there, stay safe, stay well, stay curious, and look forward to seeing you on the next MJ Health webinar. All the best.